Today I'm going to discuss about the Mrcp Paces Neurology Station, and we're going to discuss a case of 6th nerve palsy. This is a very common case which can present in the neurology station, and it's a quite simple case as well. So let's move on to our presentation. This is our case scenario. Mr. Smith, a 45-year-old man, presents to the neurology clinic with a complaint of double vision that has been present for the past week. So if you see any symptoms which are related to vision, or any movements of the face or anything which are related to the cranial nerves, then you should automatically think that you have to do the cranial nerve examination, or your main focus should be in the cranial nerve examination. Obviously, you're going to do the other examination as well, but mainly focus on the cranial nerves. So in this case, the patient is complaining of the double vision. First of all, you're going to once you enter the room, you're going to introduce yourself, you take consent from the patient and do the inspection first. So after you're done your inspection, then you will move on and you look for any movements, extraocular movements of the eye. So assess the range of movements of both eyes and all direction of gaze, including up, down, right and left, and look for any restrictions or limitation in eye movements which may indicate dysfunction of other cranial nerves or the ocular muscles. So here you can see that while the patient, if the patient was asked to look on the left side, so you can see that the right eye, it can move medially. However, the left eye is not able to move laterally. So this is a most likely 6th nerve palsy. Here is another example. From looking straight, is okay. Both eyes are in the middle, but when the patient is asked to look towards the right side, you can see that the left eye can move medially. However, the right eye is unable to abduct. So this is most likely a 6th nerve palsy. You're going to proceed with the pupillary examination as well, because we want to evaluate the pupillary size and symmetry and reactivity to light, and also assess for the relative afferent pupillary defect, which may suggest the optic nerve dysfunction. You'll do the complete cranial nerve examination, so look for the visual field examination as well. So we're going to perform the confrontation visual field testing to assess the peripheral vision, and look for any visual field deficits such as homonymous or myopia, which may indicate lesions affecting the visual pathway. You will do the fundoscopic examination in this station, because as the patient complaining of diplopia is very important, and perform to assess the optic disc and retinal vasculature, and look for any signs of papillar edema, any optic disc edema or other abnormalities that may suggest an increased intracranial pressure or optic nerve pathology, because increased intracranial pressure is one of the differential diagnoses of isolated 6th nerve palsy. Then you're going to move on and do the motor examination as well. So you evaluate the muscle strength and tone in limbs, particularly in the context of associated neurological symptom sign, and look for any signs of weakness and spasticity or abnormal movements, because they may indicate the central nerve system pathology causing the 6th nerve palsy. You're going to do the sensory examination as well, so assess the sensory modalities including the light touch, pinprick, proprioception and vibration sense in the limbs and face, and look for any abnormalities which suggestive of sensory deficit or peripheral neuropathy. Coordination and gait assessment, so evaluate coordination by performing the tests such as finger, nose, finger and heel chin test, and assess the gait for any abnormalities such as ataxia or spasticity, which may suggest cerebellar or brainstem dysfunction. Reflexes, test the deep tendon reflexes, bicep, tricep, knee and ankle, and superficial reflexes like plantar reflex to assess for upper or motor neural involvement. And mental status examination, assess any cognitive function including the orientation, memory, attention, language and executive functions. And so look for any signs of altered mental status, confusion or cognitive impairment. So remember these things, although the patient has presented with diplopia, but although this is a short station, but you have to focus on the cranial nerves, but need to do the other examination also, although it will be just a brief examination, the motor examination, sensory examination, and don't forget the fundoscopic examination. What are the differential diagnoses? We can have an isolated sixth nerve palsy, and this is most likely case in this scenario, which is characterized by the weakness of the lateral rector muscle due to dysfunction of the abducens nerve. If there are no other pathologies involved or no apparent other neurological deficit, then you can safely say this is isolated sixth nerve palsy. Other differential diagnoses include brainstem lesions, so lesions affecting the brainstem, like any tumors or any demyelinating diseases, may also result in sixth nerve palsy. Raised intracranial pressure, conditions leading to elevated intracranial pressure such as idiopathic intracranial hypertension or any mass lesions, they can also compress the abducens nerve. Vascular causes, or like ischemic events or vascular abnormalities affecting the abducens nerve, and inflammatory conditions like multiple sclerosis or autoimmune disorders, they may affect the cranial nerves, including the abducens nerve. How about your investigation approach? Obviously, going to do the neurological examination, so we need to do the detailed examination of the cranial nerves, including the assessment of other neurological functions. Imaging studies, MRI of the brain and brainstem. We want to evaluate for any structural abnormalities for lesions. We will be interested in doing the CT scan as well, if MRI is contraindicated. We want to do some blood tests as well, like complete blood count, inflammatory markers, and specific tests based on clinical suspicion. And EMG or nerve conduction study may be performed to assess the nerve function. This is briefly about the investigation approach. What about the management? We want to do the treatment for the underlying cause. So management will depend on the underlying etiology. For example, if the cause is determined to be a brainstem lesion or there is an increased intracranial pressure, the appropriate treatment will be initiated. In case of symptomatic treatment, we were talking about symptomatic treatment of diplopia. So we can use some prisms or patching and or occlusive therapy for these symptoms, and follow-up and monitoring. So regular follow-up appointments to assess for resolution of or progression of symptoms and to adjust management as needed. So this is our case presentation. Mr. Smith is a 45-year-old gentleman presenting with a 1-week history of double vision. On examination, he has reduced lateral movements of the left eye, which is consistent with the sixth nerve palsy. And then you're going to mention about the differential diagnosis. So the differential diagnosis, they include the isolated sixth nerve palsy. It can be brainstem lesion, increased intracranial pressure, vascular causes, and inflammatory disorders. And then you're going to mention about the investigations, which will include MRI of the brain, blood tests, and possibly electrodiagnostic studies. And management will involve treating the underlying causes and symptomatic relief of diplopia. So in the case presentation, remember, always divide the case presentation into different groups, so at that time you don't forget anything. So whenever you present the case, briefly give some history. Whatever history is written here, you can repeat that one. And then you give your examination findings. Here we see that there is a reduced lateral movements of the eye. Then you're going to just continue, don't stop there, talk about some differential diagnosis as we have mentioned in your investigations and the management plan. The examiner may stop you at any point, but if the examiner doesn't stop you, you just continue with your presentation. So some of the questions which are commonly asked, we have covered almost everything. What are the common causes of sixth nerve palsy? So common causes include trauma. It can be vascular lesions such as ischemia, tumors including brainstem lesions, increased intracranial pressure, infections, and inflammatory conditions such as multiple sclerosis. How would you differentiate between isolated sixth nerve palsy and other causes of diplopia? So isolated sixth nerve palsy, it typically presents with specific deficit in lateral gaze, leading to diplopia when attempting to look towards the affected side. Other causes of diplopia may be associated with some additional neurological signs such as involvement of multiple cranial nerves. There may be change in consciousness or some focal neurological deficits. What investigations would you consider in the management of this patient? We have already covered this, just the repetitions. So investigation may include the MRI of the brain and brainstem to identify any structural lesions, any vascular abnormalities, or signs of increased intracranial pressures. Sometimes we also need to do the blood test, particularly looking at the complete blood count and inflammatory markers to assess for any systemic conditions or infections. And in some cases, we maybe have to do the lumbar puncture, especially if you're thinking about raised intracranial pressure. So how would you assess for the presence of diplopia during the clinical examination? So diplopia may be assessed by asking the patient to fixate on a distant object and then bringing a finger or pen into the patient visual field in different directions of gaze. And the patient is asked whether they see one or two images of the object. And this is one method. Or alternatively, the examiner can use a cover-uncover test to detect the ocular misalignment and confirm the presence of diplopia. Another question which may be asked, what are the potential complications of untreated sixth nerve palsy? So untreated sixth nerve palsy can lead to chronic diplopia. It can decrease the quality of life and difficulty with daily activities like such as reading or driving. And additionally, patient may develop compensatory head positioning or strabismus, which can result in amblyopia, which is reduced vision, or binocular vision disturbances. Another question which is asked is, what is the role of botulinum toxin injection in the management of sixth nerve palsy? So remember that botulinum toxin injections, they may be considered in very selective patients with persistent or severe sixth nerve palsy causing significant diplopia. So by selectively weakening this medial rectus muscle of the contralateral eye, it can help to alleviate the diplopia and improve the ocular alignment. However, remember that this is in the very selective patients, so it is essential to weigh the potential risks and benefits of this treatment option and consider it in consultation with a neurologist. Finally, what are the red flags in the history or examination that may suggest an urgent underlying cause of sixth nerve palsy? So red flags are sudden onset of symptoms, if the patient has associated headaches or altered consciousness, if we have a progressive neurological deficit, or signs of increased intracranial pressure. So these findings warrant urgent evaluation for possible intracranial pathology like mass lesions or vascular events. So they require emergent imaging and neurosurgical intervention. So hopefully I've covered everything in the sixth nerve palsy case. And remember that whenever you go for the Mrcp PACES examination, the key is the confidence. So remember your steps, remember how to examine the cranial nerves, and remember the differential diagnosis. And this is a quite easy case in the neurology, and hopefully all of you will do well. Thank you very much, and I'll see you in my next presentation.